Hello, everyone. This is the second lecture today on neoplasia or medications, drugs for cancer. And we will go over the medications that would treat patients with different types of cancer. So last week we went over some of the slides about the pathophysiology of cancer, neoplasia, and 3 steps or phases of the disease process, how it progresses from initiation to progression and to the last stage, and the difference between benign and metastatic or malignant tumors, and the methods of metastasizing or metastasis. So the first few slides provide the prevalence and some of these statistics or epidemiological concepts and numbers and about the cancer disease. So let's go to slide that talks about the regulation of division, of cell division. So we said that the cancer develops as in 2 major dysfunctions that are involved in the process of disease of cancer development. The first one is the defect in proliferation, which is the growth of the cells, and the other defective phase will be during the cellular differentiation of the cells. So the 3 phases of the disease process of the cancer, how it develops, is that we'll start with the initiation phase. And last week went over the different carcinogens that would put the patient or the individual at risk to develop the cancer. And all of these, we included all the risk factors that will lead to or cause cancer. Alcohol, radiation. We went even over the some of the inflammatory diseases like carcinogens, and so we can review them. Go back and review some of these carcinogens one more time. So we said that carcinogens are any agent or factor or chemical or that may predispose the patient to develop cancer. So there is a gene environment interaction and risk factors. So the carcinogens are the agents that can cause cancer and that are capable of producing the cell alterations or changes in the cells. So some of these chemicals, we said the alcohol, arsenic, formaldehyde. The alcohol we listed here, all of the mechanisms that may promote carcinogenic action due to exposure or ingestion of alcohol, and then radiation We included all the different types of X-ray or any other radiation exposure that may predispose the individual to develop cancer. Then we went to radiation, sorry, um, to chronic um, inflammation and chronic irritation and inflammation, like patients who develop the IBD, for example, irritable bowel disease for more than 10 years. They will be at increased risk for developing the colon cancer or colorectal cancer, CRC, to about 30-fold compared to other counterparts who are healthy. So the chronic liver inflammation like hepatitis hep B or hep C and liver cancer, also another risk factor as a form of chronic inflammation or infection. Chronic asthma and lung cancer, NSAIDs. Well, they found that the aspirin and ibuprofen, since they inhibit the COX-2 enzyme that generates prostaglandin during chronic inflammation, that these products are protective against the colon cancer. So the NSAIDs, they found some of the studies kind of indicated the positive outcome as protective against colon cancer, the NSAIDs. Viral carcinogens. All different types of viruses or viral infections that may lead to different type of infections. So I listed almost all different types of viral infections here that may predispose the individual to develop the infection. And that takes years for these type of infections to become carcinogenic and lead to cancer. An example of this would be the chronic hepatitis that may eventually lead to hepatic cancer. The cervical cancer is due to infection with human papilloma virus, HPV. Occupational hazard. And how is the asbestos mesothelioma may lead to lung fibrosis or lung cancer. Certain type or manufacturers of dyes, like the people who use the hair dyes are exposed to the hair dyes, like the who works in salons or exposed to the hair dye, they are at risk to develop the bladder cancer. And leukemia is also associated with the different types of occupations listed up here. And we also mentioned that the smoking tobacco use as one of the complete carcinogens, one of the proven to be identified as a complete carcinogen that leads to may lead to cancer. Hereditary genetic predisposition, diet, obesity, all of these are different types of risk factors that may lead to cancer. So the development or the three phases of cancer development. So the cancer develops over three phases. The first phase, which is initiation, and then promotion. So we'll go back to the first phase, which in which that we have went covered or went over what is called the proto-oncogenes and the tumor suppressor genes, and we did differentiate between the proto-oncogenes and the tumor suppressor genes last week. So the three phases are the initiation phase and the promotion and progression phase. So the first phase, which is the initiation, which is the first exposure or the individual's exposure to the carcinogen, if that's an ingested chemical or inhalation or skin exposure, but that's some type of exposure or X-ray radiation or any type of radiation and other types of radiation or any type of agent exposure. So the first phase is the initiation phase, and usually it takes years until the patient or individual will enter the second phase, which is the promotion phase, which is characterized by reversible proliferation of altered cells. Even still at this phase or of the disease process, is that there is some high extent of reversibility of the proliferation of these altered cells will be reversible. So the the activities of promotion are reversible, and that has to do with other factors or any an additional factors other than the factors that have been involved in the initiation phase. This makes the condition worse and will promote the disease process even to higher levels. So there is a latent period, and then which takes from 1 to 40 years for disease to progress and develop, and then the progression phase, which is the last phase, in which there is an increased growth rate of tumor. There is some invasiveness and some unprobable metastasis. These are some of the most frequent signs of metastasis, like lungs, brain, bone, liver, adrenal glands, and the metastasis. There are some theories that explains how metastasis would take place in terms of the metastasis. Either it's at the local level, which is like local seeding, or the metastasized cells or malignant cells will be shedding off or get detached from the tumor itself and travels through lymphatic fluid or through the blood vessels, and that's how these cancer cells will travel to either adjacent cells or to distant places or organs and cells. And that's what is called metastasis, either through the local seeding or to distant cells and tissues and organs. And in both cases, we call that metastasis, either to adjacent or distant organs. And there are a few mechanisms how which makes the cancer cells immortal and make them or add to their survival, is that the cells are able to produce their own or manufacture and make their own blood vessels in a process called neovascularization, which is angiogenesis. Angiogenesis, which is the ability of these cancer cells to create their own and develop their own blood vessels, and by doing having the ability to produce the enzyme called vascular endothelial growth factor enzyme, which is responsible for the development of these blood vessels, so the cancer cells can survive on the blood perfusion of their own blood vessels. And one of the medications that was manufactured and was released in the market for a long time ago, is called Avastin, and that's the medication that is based on the concept of the antagonizing the enzyme, the VEGF enzyme. So the first drug approved to treat cancer by preventing angiogenesis is the Avastin, because it will inactivate that VEGF enzyme, so it will prevent the cancer cell from making their own blood vessels. So that will result in their death of the cells. The other feature of the cancer cells that they are immortal is that they will never die. Is that they are the ability of these cells to have to live with is that they produce an enzyme called telomerase enzyme, and this enzyme is responsible for natural, human beings, they don't have this enzyme because the life cycle for any cell or every cell is that it requires that this telomere, which is the last section or segment of the DNA, gets shorter with every cell division becomes short. So until the last section or segment of the telomere, then when it's finished or done, that is the end of the cell. So which is results in the death of the cell. So the cell dies when the telomerase and when the telomere section or telomere of the DNA disappears. Because we remember with each cell division, this telomere becomes short and short until it disappears. Now, cancer cells are able to produce their own telomerase enzyme that will maintain the telomere at its normal length, and it's will never disappear. So it will maintain the cell to stay alive, and that will result in that the cell is cancer cells are called, they are not immortal, they will never die. So that is another feature or the ability or mechanism how the cancer cells are able to survive. Another mechanism that makes the big challenge to immune system to identify and detect these cancer cells, because they were cancer cells supposed to be foreign bodies, and the immune system supposed to catch them or detect them as a foreign bodies and destroy them. However, that the cancer cells, they are able to produce their own antigens. They are tumor-associated antigens, TAA. Tumor-associated antigens, TAAs, are the antigens on the cancer cells on the cell surface. But the cancer cells also, they will produce their own antibodies. So these antibodies will cover these antigens and will never be detected by the immune system, by the T or B lymphocytes as foreign bodies. So they will evade the immune system. So that's another mechanism how the cancer cells will survive and evade the immune system and keep multiplying and replicating and create that huge tumors and then metastasize to other organs. There are enzymes that the tumor cells are going to secrete. So these are called tumor markers, and we can detect diagnose. We can also manage the patient's treatment, like chemotherapy or radiotherapy, with using these tumor markers. So CEA titers after surgery that would indicate that the tumor was not completely removed. So CEA titers, that's an indication of that the enzyme in it reflects that that the presence of the tumors, the tumor, its size. We can tell, or at least we can indicates that the tumor activity when we get these CEA titers. There are too many of these, two different numbers of CEA titers, but these are the enzymes that are produced by the cancer cells. And so we call these tumor markers. There are also other tumor markers like these are some other types of tumor markers, but we have also tumor markers like AFP, alpha fetoprotein, which is a tumor marker for liver cancer. Other tumor markers for prostate, like PSA, prostate-specific antigen. That's tumor marker for prostate. Extremely high levels of PSA indicates the prostate cancer. Now, staging or benign versus first, they differentiate benign versus malignant tumors. So there's one slide that will differentiate between malignant versus benign tumors. So benign neoplasm and malignant neoplasm. So benign is supposed to be just benign tumor, not cancerous, but malignant is definitely a cancer that could result in metastasis. Now, when it's benign, it's growing slowly, but the malignant tumors is usually growing rapidly. The benign tumors, they usually are well differentiated and they are within like a sac or within a capsule, like well-defined capsule, but they are encapsulated. But the malignant tumors or neoplasm, they are usually not encapsulated and they are very diffuse and they have a high vascular blood vessels. So the moderate to marked vascularity, that the benign usually didn't have a good blood vessel or like perfusion per se. So the benign, they usually do not have the ability to metastasize or be invasive to other tissues, but the malignant tumors usually they can infiltrate and they can have the ability to expand and be invasive to adjacent or to distant organs and tissues, and which is, in other words, we call that metastasis. Now, staging. There are different mechanisms to stage, different classification systems to stage the cancer. So it can be done. There are different classification systems. One of them is called, we can classify like grading, like grade 1 through 4, and the other one from 0 to 4. And then we have another very common classification system called the TNM classification system. So this classification system identifies and describes the tumor in terms of the two things, two sub-classifications based on the tumor size and if there is an invasiveness, T, and then the spread of lymph nodes, which is indicated by the N or represented by the N, and then M will indicate if there is any metastasis. We have clinical staging and surgical staging, so this can be done through the surgical procedure. The classification, we can also classify the cancer, different cancer types or different types of cancer based on the anatomic site like when it originates from the epithelial cells, we call it carcinoma. If it originates from the connective tissue, like bone, muscle, we call it sarcoma. From the lymph or from the hepatopoietic system, we call that like lymphoma or leukemia. Metastasis, we said there are three different modes of metastasis or routes, through either through the local seeding, like shedding of cancer cells to local area, and that's sometimes what some of these surgeons are very reluctant to um, operate on some of the tumor of patients with some type of tumors, because the sometimes manipulating the tumor would result in metastasizing and shedding off these cells to enter the bloodstream or lymphatic fluid, and that will result in metastasis. And the other route of the invasion will be through the blood, and the last one is the lymphatic spread. So some of the sites of metastasis based on the cancer type, like when patients with breast cancer, they may have, untreated or, undiagnosed. Sometimes it metastasized, will metastasize from breast tissues to the axillary lymph nodes, the lungs, to the liver, to the bone, to the brain. So colorectal cancer to the liver, lung, peritoneum, and so forth. So each type of cancer, which is, the first one is called primary cancer, and then the second one is called the secondary cancer, in which that, has, that cancer cell has metastasized too. So the first initial is the primary cancer, like lung cancer. And then when it metastasizes to the liver, the liver cancer becomes a secondary cancer that is the metastasized too. Um, Diagnosis and treatment will be the focus in adult health too. You can also listen to that recorded video that I posted on Blackboard, which explains about the different diagnostic procedures and diagnostic tests and diagnostic studies for to diagnose patients with cancer or different types of cancer. So I'm going to focus on the uh, uh, treatment of patients with cancer. So we'll focus on the medications, surgical, radiation, and other modes and modalities of treating patients with cancer. Again, will be covered in adult health too, but for a beta forum, we'll be focusing on the drugs and medications treating, as a chemotherapy to treat patients with cancer. So we have the antineoplastic therapy, which is with what is called the chemotherapy. So um, the effect on cells, these chemotherapies, they're effective against dividing cells. So the cancer cells will escape the death by staying in the G0 phase. If you go back to the different phases of the cell cycle and cell cycle, you will find that the effect that the antineoplastic therapy, the chemotherapy, they're effective against dividing cells. So cancer cells escape death by staying in the G0 phase, which is the resting phase. Now, the chemotherapy classified as molecular structure or mechanism of action, and the um, drugs may be absorbed through either the skin or through inhalation or through the touching, the transportation or the administration. As we prepare these medications, we have to be careful to um, properly. So we have to apply the um, the like gloves, and at some point, or some certain drugs they have to apply even the gown. So the trained personnel should handle these medications, and should not be administered by anyone who is not trained or properly trained to administer these meds. So we have to be careful not to have that, bare hands, or like not to don or wear gloves, and or even face shield. I mean, sometimes we have to apply other PPEs as applicable or as needed. So we have oral, we have IM, we have intravenous chemotherapies. There are different formulations of chemo. So types of regional delivery methods. Now, regional administration of chemotherapy, which will deliver the drug directly to the tumor site. You can administer the chemotherapy intraarterial, which will deliver the drug through arteries supplying a tumor, intraperitoneal, which will deliver the drug to the peritoneal cavity or for the treatment of peritoneal metastasis. If the drug of the cancer cell has metastasized to the abdomen or peritoneum, so we can introduce that or administer it intraperitoneal. Intrathecal or intraventricular, that involves the lumbar puncture, spinal tap, and injection of chemotherapy into the subarachnoid space next to the spinal cord within the CSF. Intravesical bladder, so that will be the agent added to the bladder by urinary catheter and retain that for 1 to 3 hours. Radiation therapy, again, this will be extensively covered in adult health too. These are the common side effects of chemotherapy, especially the dry desquamation or wet desquamation of tissues. So for this question, the answer is C. The combination of radiation and chemotherapy reduce the chances of developing side effects. So the nurse should encourage discussion of issues related to reproduction, offer specific suggestions, and make referral for counseling. Immunotherapy, targeted therapy. That's these other modalities to treat patients with cancer. And again, these are some of the side effects to the immunotherapy and targeted therapy. And all of these modalities will be covered in adult health too. So the answer to this question is B, encourage the patient to implement daily walking program. And again, this might be an question for adult health, not the path of harm, but we have to encourage the patient to implement a daily walking program, exercise and activity uh, within tolerated limits are often helping or very helpful to the patient in managing patient's fatigue. And walking programs are ways for most patients to stay active without being over exhausted. Hematopoietic stem cell transplantation is another modality to treat patients with cancer, in addition to the gene therapy, complications of cancer, especially um, when the patient developed the wasting syndrome and cachexia and significant weight loss, in addition to the others. Others will be side effects, but these are the most concerning complications: malnutrition, altered taste sensations, cancer cachexia, and wasting syndrome. Infection is another significant problem or complication, given that the patient's immune system will be compromised due to the use of different medications like chemotherapy or radiation and others. So the cancer cell, the anti-cancer drugs, or like, especially here is we will focus on the chemotherapy um, that will result in adverse effects like alopecia, mucositis, nausea and vomiting, and vesicants. In terms of that, the medications, they will cause a um, tissue injury if extravasation occurs. So some of these chemotherapeutic agents, they are vesicants in which that they result in extravasation. And so we have to know the emergency treatment before giving the vesicant IV. Cyclophosphamide, which is cytoxan, which is the drug that would attach to the DNA and disrupt the replication of the cancer cell. That's a mechanism of action of cytoxan. It's an immunosuppressant, or at least it will result in immunosuppressant effect. It will also decrease the platelet counts. Thrombocytopenia would result. You know, in addition to other side effects like nausea, vomiting, anorexia, so it's all the GI symptoms, alopecia, and hemorrhagic cystitis. So it's an antineoplastic drug, anti-cancer medication. The drug class or pharmacologic class would be an alkylating agent. This is a powerful immunosuppressant, and it can treat It's very effective in treating patients with Hodgkin's disease, lymphoma, multiple myeloma, breast cancer, ovarian cancer, um, and it is one of the only few anti-cancer medications that are well absorbed when given orally, PO. It's a powerful immunosuppressant. While this is considered as an adverse effect during cancer chemotherapy, the drug is used to intentionally cause immunosuppression for the prophylaxis of organ transplant rejection and to treat severe rheumatoid arthritis or SLE, systemic lupus erythematosus. So administration alerts dilute prior to IV administration. We have to monitor the platelet count because one of the side effects is thrombocytopenia prior to IM administration. And if the platelet count is less than 140,000, we have to hold the drug, hold the dose that day. And to avoid GI upset, all these, but we listed all these previously, all the GI symptoms, adverse effects from the drug, the GI symptoms, take with meals or divided doses. So the most significant or serious adverse effects is the bone marrow suppression, which is potentially life-threatening adverse reaction. Usually it will occur during the days 9 to 14 of therapy. The patient is at dangerous risk for severe infection and sepsis during this period. So you have to be careful, and at some point, maybe we have to maintain the neutropenic or reverse isolation. Thrombocytopenia is common, although less severe than with many other alkylating agents. Compared to other alkylating agents, it's less severe than other agents from the same group. Nausea, vomiting, anorexia, diarrhea, all frequently experienced by patients who take this medication. Also, their drug cause or result in alopecia, although the hair may regrow with a different color or texture. None of these metabolites of the cyclophosphamide or acetoxan may cause hemorrhagic cystitis if the urine becomes concentrated, which means that patients should be advised to maintain high fluid intake during therapy. The drug may cause permanent sterility in some patients. And compared to other cyclophosphamide, cytoxan has compared to the other alkylating agents, the cyclophosphamide cytoxan exhibit little neurotoxicity compared to other alkylating agents. So immunosuppressant drug used concurrently with cyclophosphamide will increase the risk of infections and further development of neoplasms, cancers. There's an increased chance of bone marrow toxicity if cytoxan is used concurrently with the allopurinol. Allopurinol, which is a drug to treat gout. So it's a anti-gout medication or drug. So there's an increased chance of the bone marrow toxicity if cytoxan is used concurrently with allopurinol. There's an increased risk for bleeding if um, cytoxan is given with anticoagulants. If used concurrently with digoxin, decreased serum levels of digoxin will occur, decreased level of digoxin will occur. So use with also with insulin may lead to hypoglycemia. Now, when planning care for a patient who is receiving cytoxan or cyclophosphamide, it is most important for the nurse to include which intervention to prevent complications of cytoxan therapy. Answer is D, which is to increase the IV and oral fluid intake, because it's the cyclophosphamide is the alkylating agent with adverse effects of dose-limiting bone marrow suppression and hemorrhagic cystitis. Bladder injury can be minimized by maintaining adequate hydration through increased fluid intake. So it's not necessary to monitor the patient for laryngeal stridor or tetany, palpate pedal pulses, or give an antidiarrheal medication with cyclophosphamide. Antimetabolites like methotrexate, we have there are three different types of antimetabolites. These are the medications that act by disrupting the critical pathway in cancer cells, like the folate metabolism or DNA synthesis. So we have three types like folic acid analogs, purine analogs, and pyrimidine analogs. So just to know that there are three different analogs. One's folic acid, one is purine, one is pyrimidine, pyrimidine. Three different analogs of antimetabolites. So the most common one, which is the prototype, is methotrexate, MTX, Remotrix, or MTX, the abbreviation. So it blocks the synthesis of folic acid, which is vitamin B9, to inhibit replication of the cancer cells. To treat, it will treat different types of cancer, as included here as primary use. Adverse effects, fatal bone marrow toxicity or suppression, especially when we administer the MTX or methotrexate at high doses. Hemorrhage, bruising, low platelet count, nausea, vomiting, anorexia, gastrointestinal ulcerations, intestinal bleeding, and with toxicity, we will find that there is a deep, bloody oral mucosa with severe ulcerations of the oral mucosa. So antineoplastic drug, antimetabolite, but it's a folic acid analog. So it's available and can be administered oral, parenteral, intrathecal. So by blocking the synthesis of folic acid, the drug inhibits the replication, particularly in rapidly dividing cells. So in addition to that, it's an anti-metabolite, anti-cancer drug, but also it's a powerful immunosuppressant drug. So that's why it's been used or effective to treat patients with severe rheumatoid arthritis or ulcerative colitis or psoriasis, because of the fact that um, it's effective to inhibit replication in rapidly dividing cells. And all of these conditions, they include that process. So methotrexate carries multiple black box warning combined with NSAIDs. They may cause severe and to some extent, sometimes fatal myelosuppression, suppression of the bone marrow, which is a primary dose limiting toxicity of this drug. It's dose limiting toxicity. So high doses of MTX or methotrexate will result in this fatal myelosuppression. The drug also is hepatotoxic and may cause liver cirrhosis with prolonged use. Ulcerative stomatitis and diarrhea requires suppression of therapy because they may lead to hemorrhagic enteritis and death from intestinal perforation. So it can lead to intestinal perforation as a serious complication from this drug. Opportunistic infections could also result as a potential fatal infections, pneumocystis, pneumonia may occur, take place during the therapy. Pulmonary toxicity may result in acute or chronic interstitial pneumonitis at any dose level. So this is not associated with high doses. It can occur at any dose level. And the last one will be the dermatologic reactions, such as toxic epidermal necrolysis and the SJS, which is Stevens-Johnson syndrome. It has been reported as side effects from this drug. So when massive doses of methotrexate are given, sometimes we have to give large doses of methotrexate. So leucovorin drug is used to protect normal cells when massive doses of MTX are given. The drug is called leucovorin, which is LEUCOVORIN, leucovorin. That's a drug that's been used to protect normal cells when massive doses of methotrexate are given. Methotrexate is teratogenic, so it's contraindicated in pregnant women. Immunosuppressed patients or those with blood dyscrasias, like severe anemia or hemolytic anemia, should not receive methotrexate. The use of the drug with alcohol may increase the hepatotoxicity of the methotrexate. Resistance to the drug, to methotrexate. The resistance to methotrexate may occur through 5 mechanisms, but there is the what is called resistance to the MTX. And one of the mechanisms is reduced uptake of the drug into the cells, or due to the increased production of the transporter pump, or increased synthesis of the dihydrofolate reductase and decreased ability to convert the drug. You don't have to know about these mechanisms, but these are 5 mechanisms of which or in which that there will be at some point a resistance to the MTX. Anti-tumor antibiotics. The prototype drug is the adriamycin, doxorubicin, and the antineoplastic drug of this type is the class is anti-tumor antibiotic, but it's an antineoplastic anti-cancer drug. So the adriamycin, it attached to the DNA, it will distort the double helix, which is the double-stranded DNA, and prevent the DNA and RNA synthesis. It is only administered by IV infusion. It is broad-spectrum cytotoxic antibiotic prescribed for solid tumors, bone, GI, thyroid, lung, breast, ovary, bladder, and for various types of leukemia and lymphomas. And it's considered as one of the most effective single drugs against solid tumors. Administration, the extravasation can cause severe pain and extensive tissue damage. The skin contact or extravasation should be treated immediately with localized packs to reduce absorption of the drug. For infants and children, we have to verify the concentration and the rate of the IV infusion with healthcare provider, because that's critical to verify the rate and concentration of the IV infusion. So first question, a nurse is preparing to administer the adriamycin IV to a patient who has breast cancer. Which action should the nurse take? Answer is place the patient on a cardiac monitor, so B. Tell the patient the urine turns red, C. Ensure the patency of the IV site. Doxorubicin or adriamycin, it's an anti-tumor antibiotic with cardiotoxic adverse effects. Cardiac activity may be assessed with a monitor because acute dysrhythmia and EKG changes can occur within minutes of administration of this medication. The medication imparts a harmless and color to urine. IV patency is critical because the adriamycin is a vesicant and can cause significant local tissue damage or injury if extravasation occurs, and it's not necessary to infuse normal saline for 24 hours before administration to give a diuretic after the infusion. The second question, the nurse assesses the the patient receiving the fluorouracil for the adverse effect of uh, plantar erythrodysesthesia. So what are the characteristics of this syndrome? So this one is I included that just to highlight the drug, not to go over the syndromes. The adverse effects of fluorouracil, one of the commonly used anti-cancer drugs, that's one of the side effects of the drug, which is the plantar erythrodysesthesia, which is hand and foot syndrome. It's called hand and foot syndrome, which is characterized by like a tingling, burning sensation, redness, flaking, swelling, some type of blistering of the palms and the soles, affects the palms and soles, all these changes, tingling, burning, redness and flaky skin and swelling, blistering, that's to the palms and soles. So the hyperglycemia and hypertension are not characteristics of the syndrome, but these are what I described earlier, that these are the characteristics of the plantar erythrodysesthesia, which is the what is called hand and foot syndrome. Vincristine, which is plant extracts and other natural products to treat patients with cancer. This is this, it kills cancer cells by preventing cell division. So we call them the mitotic inhibitors, and there are different, like 4 different groups of these mitotic inhibitors. So vincristine is another. Oncovin is a very common, very old, common, effective drug for cancer. Primary use is Hodgkin's and non-Hodgkin's lymphoma. Other would be like leukemias and Kaposi sarcoma, Wilms tumor, bladder carcinoma, breast carcinoma. So vincristine is a vesicant in which that the extravasation of these agents can cause severe local injury or damage that sometimes requires surgical debridement and or skin grafting. The site should so the vincristine, again, that's a vesicant that may result or lead to a extravasation of the and leakage of the drug into the under the skin and the adipose or outside the blood vessels to the interstitial space and leads to result in or lead to a severe local damage to the tissues, which may require eventually for the surgical debridement or skin grafting. So vincristine is specific to the M phase of the cell cycle, which in which that it will kill the cancer cells by preventing their ability to complete the mitoses. Although the vincristine must be given IV intravenous, its major advantage is that it causes a minimal immunosuppression. So it's very effective to treat different types of cancer like Hodgkin's and Hodgkin's lymphoma, Kaposi sarcoma, Wilms tumor, bladder carcinoma, and breast carcinoma. So if extravasation occurs, may result as serious tissue damage Then we have to stop the infusion immediately if extravasation occurs, and then we have to apply um, local heat and inject there is a medication called um, hyaluronidase that will be ordered and then it has to be applied and to observe the site for any sloughing. Vincristine peripheral neuropathy is one of the major dose-limiting toxicity of vincristine, peripheral neuropathy. So patients should be canceled to report any tingling of the extremities. Hormone antagonists. So we have tamoxifen, then we have the estrogen receptor antagonist, the ER medications. So the antineoplastic drugs slow growth of the reproductive related tumors, prostate, urine. They're less toxic than other antineoplastic drugs, like tamoxifen. It will block the the estrogen receptors. So there are ER medications, estrogen receptor antagonist, and they are specific on to the breast cancer cells. So primary use will be for patients with breast cancer, also given to high-risk patients to prevent the disease. It can be given also as a preventive measure as well. It can cause nausea, vomiting. And it's associated with increased risk of endometrial cancer and the thromboembolic disease like PVT and PEs. Now, for the tamoxifen and the drug-drug interaction, the inhibitors of the CYP2D6, which is an example of that would be the sertraline, which is the Zoloft. It can negate the benefit of the treatment with tamoxifen. So the antidepressant sertraline or Zoloft can negate and antagonize the benefits of treatment with tamoxifen. So patients on sertraline or Zoloft, they should request switching to a different or another antidepressant medication, such as like citalopram, for example, Lexapro, instead of Zoloft, because that will Zoloft will antagonize the effect of the tamoxifen. Two more drugs for cancer. The first one is called the um, trastuzumab, which is the Herceptin. It's very effective, very commonly prescribed drug, and it can be used to treat the hormone estrogen receptor 2 positive breast cancer. So this is a type of breast cancer called the HER2 positive breast cancer. So very effective for this type of breast cancer, and that is in either the early stage or even advanced stage of this type of breast cancer. So Herceptin is currently approved by the FDA to treat metastatic HER2 positive breast cancer, to stop the cancer from growing, to treat earlier stage of also positive, so either to at early stage or advanced stage. It can be either as part of the regimen with chemotherapy or alone after a chemotherapy regimen that includes other medications. So it can also be given to reduce the risk of the breast cancer coming back, like recurrence in combination with other medications. So it can also given to reduce the risk of recurrence of breast cancer. There are different uh, criteria and uses for the Herceptin. Again, but it can be given an early stage or for advanced metastatic type of breast cancer. The other medication is called Leuprolid, Lupron Depot. The drug, patient taking these drugs may initially experience an increased risk for or increase in cancer symptoms. Initially, may experience an increase in cancer symptoms that will develop, or patient will experience these symptoms until the growth hormone receptors and the pituitary gland become desensitized. So it's okay if the patient reported or reports to the nurse that, or to the practitioner, that they are experiencing an increase in cancer symptoms. That is normal for a while, because that is normal for this drug until the growth hormone receptors and the pituitary gland become desensitized. Increasing the dose is not indicated. So we shouldn't be increasing the dose of the drug, but the patient reports an increase in these symptoms. Until it becomes desensitized, then the symptoms will go away or disappear. And this concludes the lecture.